Welcome to Part 3, Care of Patients with Malnutrition or Obesity lesson. In Part 3, we are going to discuss potential nutritional interventions for the malnourished patient and refeeding syndrome. The enteral nutritional interventions include partial enteral nutrition, such as Boost or Ensure, or total enteral nutrition, also known as TEN, and this consists of carbohydrates, fats, vitamins, minerals, trace elements in a liquid form. There is a specific concentration for each client. It's provided by NG tube or PEG tube. And tube feeding care and maintenance includes verifying placement of the tube with an X-ray. There's an injection of air with auscultation over the stomach and aspiration of gastric contents. Continuous infusion is done by an infusion pump. The residual volume is checked every 4 hours or before the next intermittent feeding. If the residual is greater than 100 to 150 mLs, the feeding is delayed for at least an hour and then checked again. The fluid should be at room temperature. It should initially start out about a quarter to half strength at a slow rate and then gradually increased. Head of bed should be elevated at least 30 degrees during and after intermittent feedings and continuously for continuous feedings. There's also a chart that you can review. It's 63-5 on page 1346. There are complications of enteral alimentation. In the GI system, there's a possibility of diarrhea. This could be avoided through proper choice of feeding and slow, constant infusion. Reasons for diarrhea can be bacterial contamination, hypertonicity, and alteration in normal flora from antibiotics and proliferation of C. diff. This is usually treated with flagyl or vancomycin. In total enteral nutrition, you have the risk of aspiration, fluid excess, increased osmolarity, electrolyte imbalances, and endotracheal aspiration of tube feeding. Metabolic complications include hyperosmolar. This is an increase in older adults receiving hyperosmolar feeding products, a possibility of an unconscious patient. They have no thirst reflex. Usually they're on fluid restrictions, and then you run into the problems of hyperglycemic, non-ketotic dehydration, fluid overload, nausea, vomiting, and diarrhea. You want to make sure the head of the bed is elevated at all times if feeding is continuous, and make sure that the feeding tube's tracheal cuff is kept inflated. You also monitor, as necessary, the serum glucose. So we're going to monitor serum glucose every 6 hours, daily weight, intake and output, and liver function studies, BUN, and electrolytes. Okay, now we're going to discuss parenteral nutritional interventions. Total parenteral nutrition, also known as TPN, has a glucose concentration of 25 to 75%. It's hyperosmolar, central line only to administer TPN. When TPN is administered rapidly, water shifts into the plasma. Expansion of the plasma volume in the presence of hyperglycemia predisposes the client to osmotic diuresis, dehydration, and hypovolemic shock. Peripheral parenteral nutrition, also known as PPN, has a glucose concentration of 5 to 10%, and it's a short-term nutrition. It's only done usually up to 2 weeks. Parenteral nutrition can be provided through central vein or peripheral vein. The different types of catheters are dependent on the length of time that it's going to be provided. For short term, you can do peripheral or centrovenous catheter. For long term, you want a Hickman, a Broviac, or a Grisham catheter. And if there's a multiple lumen catheter used, infusion is done through the distal lumen only. When the patient requires intensive nutritional support for an extended time, the healthcare provider prescribes centrally administered parenteral nutrition. An example, TPN. It is a hypertonic glucose. Peripherally about 10%, centrally 25%. There are enough calories in carbohydrates or fats for maximal protein-sparing effect. There are crystalline amino acids, about 2.5 to 8.5%, essential and non-essential. The electrolytes are sodium, chloride, potassium, calcium, magnesium, and phosphorus. There is a buffer, acetate or bicarbonate, and then the minerals included are iron, zinc, copper, manganese, chromium, and selenium. It will also include the multivitamins and lipids, and other additives such as insulin, heparin, and H2 receptor antagonists. Okay, let's go over a few of the guidelines. Insertion and management is under strict sterile technique. Use of a line that has been previously used for CVP measurements or the prolonged administration of a crystalloid solution or blood products is prohibited. The port or lumen not to be used for drawing blood samples or infusing any other fluids, just the TPN. You want to discard of any cloudy solutions. There's a use of an inline filter that you have to use. It needs to be done at a constant rate. You will do dressing changes every 48 hours, and you want to discard solutions and tubing within 24 hours of hanging. You will also monitor vital signs and infusion rate at least every 4 hours, depending on the acuity of the patient's condition. You want to check the catheter site for signs and symptoms and infection every shift. You want to monitor intake and output, daily weight. You want to check serum glucose every 6 hours. You're going to check CBC, electrolytes, calcium, magnesium, phosphorus, BUN, creatinine, and total bilirubin, ALT, ASTs, uric acid, total protein, albumin, platelet count, prothrombin time as indicated. You can review a chart 63-6 on page 1348 of your textbook. It has best practice for care and maintenance of total parenteral nutrition for your review. So let's go over a few of the complications of parenteral nutrition. Decrease rate of infusion, administer insulin therapy, and monitor serum glucose levels. There is potential for fluid imbalances, electrolyte imbalances, glucose intolerance, air embolism, infection and sepsis, hyperglycemia, hypoglycemia. Hyperglycemia and hypoglycemia can occur with the interruption of TPN infusion. There can be an increased CO2 production. It may cause ventilatory distress or make weaning from mechanical ventilation difficult. And then there is the complication of refeeding syndrome. Severely malnourished patients can experience significant fluid shifts and electrolyte imbalances after aggressive nutritional support is initiated. Potentially lethal disorder known as refeeding syndrome. It is usually associated with TPN or PN, but it can also occur with enteral nutrition or EN, oral intake, or dextrose-containing IV fluids. Electrolyte disturbances also occur. There's a decreased levels of phosphorus, magnesium, or potassium that occur immediately upon rapid initiation of refeeding, commonly within 12 to 72 hours, and can continue for the next 2 to 7 days. Cardiac complications can develop within the first week, often within the first 24 to 48 hours, with neurologic signs and symptoms developing somewhat later. When a malnourished patient is given aggressive nutritional support, there will be change in insulin secretion as a result of the shift from protein metabolism to carbohydrate metabolism. This increase in glucose levels, which results from the composition of the nutritional support formula, which increases insulin release by the pancreas. Aggressive nutritional support also promotes cellular uptake of glucose along with electrolytes, primarily phosphorus, magnesium, and potassium. The result can be life-threatening depletion of these vital electrolytes, and it puts them at risk for hypovolemic shock. This is an image depicting the electrolyte level changes in refeeding syndrome. This concludes part 3 of Care of Patients with Malnutrition or Obesity lesson. If you have any questions related to this lesson content, contact the instructor.